Hi, in this video lecture, we're going to take a look at our joints. Now, imagine when you are walking and your hip joints as well as the head of the femur, they are in constant rubbing mode. And without the protective joints, then it would become very, very painful. So we're going to take a look at different types of joints and how we classify them. We can classify them based on their structural differences by taking a look at the types of connective tissues that are involved and also if there is a presence of synovial cavity. Okay, so we can classify them based on fibrous joints, cartilaginous joints, and synovial joints. So out of these three, only the synovial joints are the ones has synovial cavity. The other two, no synovial cavity. Same thing for cartilaginous, no synovial cavity. And so we'll take a closer look at all three of them. We can also classify them based on the degree of movement. So that's our functional classification. So if it's a synarthrosis, syn means together. This means it's very packed, well packed together, so most likely it is an immovable joint. And if it's amphiarthrosis, for instance, amphi, think of amphibians. So it has two characteristics. So these are slightly movable. And if you have a diarthrosis, this is a freely movable joint. Okay. So in the next table, you'll see a classification based on structure and, for instance, the fibrous versus cartilaginous and the synovial ones. And so we'll take a look at each carefully. So first, let's take a look at the structural classification of joints based on their types of connective tissue involved, as well as if there's a space, the synovial cavity. So our fibrous joints, here is an example of, for instance, the type of fibrous joints. These type of joints lack synovial cavity. So, but they are held mostly by fibers, these dense, irregular connective tissues. So we see them present in sutures, in syndesmosis, and interosseous membranes. So first let's take a look at our suture. And this is a fibrous joint showing you, for instance, between our cranial bones, we actually have our sutural ligament. So these ligaments are the ones holding our cranial bones together. When, for instance, we are younger as infants and children, these are actually slightly movable. But as we become older, these are immovable. So now some of these, actually these become, the ligaments are replaced, the sutures are replaced by bones. So when they are replaced by bones, we became a bony joint. So we call that synostosis. And these ones can, if they become bone-like or a bony joint, which is very hard, do you think it can move? No, it can't move. So these are synarthrosis, okay, immovable. Okay. Now, so this is when we become much older, yeah. And so these, when we are younger, then they are more movable, slightly movable. Okay. Now here's a couple examples of syndesmosis. Yeah. So we can find them, for instance, the ligaments that are holding our tibia and fibula together. Here are our anterior tibiofibular ligament. So these ligaments hold these two bones together, yeah, as we take a see at most joint regions. Now here's another example where our root of the tooth fits right here into the socket of your areolar process. In between, we also have the ligaments holding them together. Okay, so these are your periodontal ligament, and this syndesmosis, which is between your tooth and the socket of your alveolar process, this is called kyphosis. Okay. So these are also not very movable, yeah, to hold the two structures in place. Now, interosseous membrane is easier to see because these are between the two bones. So instead of the one earlier that we saw between the tibia and the fibula, we have these type of interosseous membrane holding the two bones together. Okay. Now, the cartilaginous joints, they also lack a synovial cavity. So as a result, they actually provide little or sometimes no movement at all as well. And we can see two types of examples in synchondrosis, which is a good example of our epiphyses. When we're growing, for instance, we have our epiphyseal plate. So these are an example of our synchondrosis. So they lack a synovial cavity. There is little or pretty much no movement here. Now symphysis, for instance, we can see an example right over here, our pubic symphysis. Okay. So remember, this is a fibrocartilaginous fibro type of connective tissue holding the two parts, the pubic regions together of your hip bone. And so it does have some movement, but usually it's only in female when they're ready to give birth. This will become much looser, so to be able to allow the baby to exit. Now, here is our third type, our synovial joint. Now, a synovial joint is very, very special, and this is the one that allows us to have a lot of movement. So between two bones, you will see what we call, and for instance, synovial cavity. And that's right over here. The synovial cavity is right, the yellow part over here, and the red part is your synovial membrane. So the synovial membrane is the inner layer, okay, inner part of it, and the outer part is your fibrous membrane. So all of these two together forms into your articular capsule, okay, that surrounds the two bones. And right over here, this region, remember from your outer region of your bone, this is your articular cartilage. Okay, so this region really provides support as well as trying to reduce friction. Now in here, your synovial cavity, okay, you have synovial fluids that are produced from the fibroblasts of your synovial membrane. So they produce these fluids and to try reduce friction, okay, when the two bones are moving. Now, for people who are double jointed, doesn't mean they have more than one joint at this region, but they have a more higher degree of ability to move. Yeah. So, but doesn't mean they have more than one joint. Okay. Now, there are some supporting structures at our synovial joints, and you'll see, for instance, besides the articular capsule, which are padded inside, we also have our ligaments. Okay, ligaments are the ones holding bones to another bone. Okay, so over here you can see, for instance, a ligament here, holding the two, for instance, glenoid-humeral ligament, holding the glenoid cavity and the humerus together. Now we also will see, for instance, bursa. These are, for instance, sac-like purses in a way. So a little bit similar to synovial type of membrane, but not exactly it. And anytime you have any inflammations of the bursas or bursae for plural, and you will feel pain and swollen and feeling over here. So it should be treated right away, or else you have a hard time moving the joints. Now we also have articular disc. These are fibrocartilage disc. Okay. And a good example is, for instance, on our knees, we can see these, the lateral meniscus and the medial meniscus. So they serve as a padding to also reduce friction. Yeah, same, you can see it here a little bit better with our oriented from anterior and versus posterior one. So all of these other structures also help regions of our synovial joints to allow them to reduce friction and allow things to be moved. Now, meniscus, for instance, as we say, is the cushioning pad, but they are made of fibrocartilage. So over here on a cross section of your knee joints, you can see the patella over here, your femur on this side, tibia on this side. So you can see the meniscus right in between. It just seems very thin right here, the meniscus in this region. Now the bursa, as we can see, there is above one region, suprapatellar bursa. There's one, for instance, prepatellar bursa right in front of the patella, your knee bone, and also one below. Okay. So these all help give support to our tremendous joints. And don't forget functional classification of the joints when you're thinking about them. Uh, Consider if they are synarthrosis, that means they are immovable. Okay. Are they amphiarthrosis, which are slightly movable? And are they diarthrosis, which are freely movable? Alright, so let's take a look at, for instance, some of the sprain versus strain. Now, you might have experienced both, but there is a distinction. So sprain is if you were to twisting of the joint and that stretches and tears the ligaments that are holding them together. So usually for this one, there's no dislocation of the bone, but you might damage the blood vessels nearby, the muscles or the tendons. And you will definitely see swelling and sometimes hemorrhage from the blood vessel. This is different from strain, which means either we have partially or overstretched muscles or the tendons that are attached to the muscles. And don't forget, tendons attaches muscles to the bones. Yeah. So if they are affected, this is the type of strain, and usually hopefully less serious injury compared to sprain. Now, our ankle sprain is one of the most common sprain injury, and a lot of people do experience it every day. So walk carefully. Yeah, there is always some bumps and dimples on the road, so be very, very careful when you walk. And also, now let's take a look at the different types of movements at our synovial joints. Our synovial joints are diarthrosis because they allow us to do a lot of movements freely. So we'll take a look at gliding, okay, angular movements, rotations, and several special movements. First, gliding. So we can see gliding when, for instance, as an example, in our intercarpals uh, joints. And so these are regions that you can move back and forth, okay, as well as you can move back and forth or side to side. a little bit for it, yeah. But there's no involve of changing of the angles of the bones. So if you were to move this way, that also counts as gliding. Now, angular movements are those that are going to cause, for instance, either an increase or a decrease of the angle between the articulating bones. So, okay, flexion, which we have seen probably when you exercise, this is what we call, will show a decrease in the angle. Okay, and extension is an increase in the angle, and we'll see some examples later on. And of extension, we may be able to see lateral extension as well as hyperextension, when it goes beyond the angle. And here is another pair, besides flexion and extension, abduction versus adduction. So abduction, think of, I know, terrible cases, but if the little kid is being abducted from home, this is the movement moving away from the midline. So think of midline as home. Adduction is the little kids have returned home, so movements toward the midline. Circumduction is a movement in the body where things will move in circle. Okay, so let's take a look at a few examples. So at our region between our, for instance, atlanto-occipital joints. So if you were to do this right now, okay, if you were to move your head below, okay, so think of this angle. This was like this, but now the angle went from here. Okay, you move when your head moves down. This is your head, so angle is less. So would this be flexion or extension? All right, moving forward, this is flexion. Okay, so when you move backwards, okay, moving back to here would be extension because now the angle has increased. Okay, extension when you're moving back. Now what if you move your neck even further, your head even backwards, more than way past this line? So that would be what we call hyperextension. Okay. All right. Is everyone all right with that? Okay. Let's take a look at our shoulder joint now. Okay. So here is our angle as well. So at our shoulder joint, okay, if we were to move our arms forward, so you can practice the same. So same thing. If our angles actually was like this, but now with your arm moving forward, it become like this. So the angle is less, so this is flexion. Oops, flexion. Okay, and if you were to move it back, increasing the angle, this is extension. And if you were to move it even further, this is hyperextension. Okay, so make sure you have a reference line. Now same here at your elbow. Okay, so if you were to bring your arms this way, okay, are you increasing or decreasing the angle? Right, you're decreasing the angle, so this is flexion. Okay. And whereas if you go the opposite way here, this is extension. Same thing, you can do the same with your wrist joint. Okay. And with our wrist joint, okay, I'll let you figure out which way is extension, which way is flexion. Okay. Now let's take a look at other angular movements. So here we actually have our, we can see this one particularly at our intervertebral joints. We can have our lateral extension. Okay. And I wanted to point out this one at our knee joints. Okay. Okay, so here is your angle. If you were to move the legs backward, okay, are you increasing or decreasing the angle? You are decreasing in the angle, yeah. So this is flexion. And if you're bringing it back, this is extension. Okay. So at each joint, it might work a little bit differently, but make sure you have your line of reference, and then you'll be able to figure out if it was flexion or if it were extension. Okay, now taking a look at abduction versus adduction. So remember which one was involving moving away from the midline? Right, abduction, moving away from the midline. Adduction is moving toward the midline. So we can apply to our, for instance, shoulder joint when you are moving your arms further away from the midline. Okay, this is the midline. So moving away, this is abduction. Moving back home, adduction. Okay. Same thing we can happen at our wrist point. And make sure you know where your reference point is, midline. Okay. Oops, midline here. Let me drop this away. Okay. Right. So if you're moving away from the midline, here would be abduction. If you're moving towards the midline, this is adduction. Okay. And oh, we have our hip joint in the middle here as well. Let's see it. Okay. Oops. So hopefully you can see a little bit with our hip joint. If your feet is moving back toward the midline, this would be adduction. Moving away, abduction. Okay. Same thing with our metacarpophalangeal joints. Okay. If your fingers are moving away, this is abduction versus adduction. Okay. So these are hopefully not too bad to identify. And circumduction is when anything is moving in a circle. Okay, so we can have that in different shoulder joints as well as our hip joints. Now rotation involves any bone, for instance a bone revolving around the longitudinal axis. Okay, so we can have that happening in our hip joints, our shoulder joint, or our when you're saying no, our atlantoaxial joints. Okay, these would be examples of rotations. Okay. Now our special movements. Okay, let's if you're moving anything superiorly, it's an elevation. So superior movement of a body part. Depression would be the opposite, right? The inferior movement of the body part. We'll take a look at an example on the next slide. Protraction versus retraction. So this is when movement of the body part is moving anteriorly versus moving it back, okay, to anatomical position. Okay, so let's take a look at an example at our temporomandibular joint. So if you were to move your jaws up a little bit, that would be elevation. How about moving it down? Right, depression. And moving, if you take a look over here, you're moving your mandible to the front. Right, that would be protraction versus moving it backwards to, this is retraction. Okay. So I'm abbreviating it, but make sure you know how it's spelled. And now, the other special movements involving the foot, okay, have inversion versus eversion. So inversion, if you were to, the movement of the foot occurs medially, okay, versus if you're moving it laterally. And we also have dorsiflexion, which is bending of the foot at the angle. Dorsiflexion would be meaning in an superior direction. Plantar in an inferior direction. So let's take a look at now more special movement before we see an example. Supination, don't forget when something is in a supine position, it tells you is a movement, right, to move things up turn upward. So we're moving here is our forearm, where our palm is now turned upward. Pronation is when our forearm is moving downward. In opposition, now if you do it right now with your thumb and any of the other rest of the fingers, doing with your opposable thumbs. Okay. Oops, THUMB. Saying, for instance, an OK sign, that's opposition. So let's take a look over here. Yeah, dorsal and plantar flexion. So I like to remember this when I relate to driving. So imagine you are driving as first, yeah? But when you're really driving, don't think about this. Yeah, pay attention when you're driving. So for instance, when you step onto your gas pedals, okay, this is plantar flexion. Okay. And when you release the gas pedal, dorsiflexion. Okay. So these will help you remember, hopefully, a little bit about it, where we see dorsal is moving it upwards and plantar is moving it inferiorly. Now, inversion and eversion, so we need to have the movements either medially or laterally. Okay, do you remember which one was moving medially? Right. So, but make sure you find your midline. Okay, this is your left foot. So, inversion, moving medially, eversion, moving laterally. Supination versus pronation. Supination when it's turning, for instance, upward. Yeah. So, turning upwards from here to here is supination. When you're turning downwards, this is pronation. And when you do the OK sign with any of your fingers, this is opposition. Okay, very good. So now you see in a summary of the movements, make sure you know which one of them, each one of them is described as, and you can actually practice this at home, yeah? Now we have 6 types of synovial joints, okay? We will take a look at each one of them carefully. So we have plane joints, and we also have those that looks like a door hinge, a hinge joint. We also have those that rotates around, the pivot joint, and those that have more of an oval shape, condyloid joints. And also we have the saddle joint, which looks more like a saddle, and my favorite, ball and socket. Okay, so let's take a look at our plane joints. In a planar, or sometimes you'll see planar joints, either or will be fine. So this occurs when we see two, for instance, flat articulating surfaces. So this will allow you to, for instance, go in back-to-back movements, or sometimes side to side, right? Okay, so, and they may be able to move in, for instance, biaxial in 2 directions, or sometimes even 3 axes. Now our hinge joints, for instance, are when we have one of the, if you look over here, one side is convex, and it fits into the other side, that's concave. So it almost looks like a hinge door. Yeah? Hinge door. Okay, so we can see that, for instance, in our elbow joints. Now here is a pivot joint, and in a pivot joint, we have, for instance, around the surface of one bone that articulates with the other side. So for instance, in a pivot joint, we actually have a bone that articulates with a ring structure, as well as you need the presence of a ligament. So if you can see over here, we have the head of the radius that fits into the radial notch of the ulna, and it needs that ligament to hold it in place. So this is going to allow rotation around that longitudinal axis. In our condyloid joint, okay, so we have projections from one bone, and both of them looks like an oval shape. So we have the convex oval shaped of one bone region that fits into the other oval shaped depression of another bone. So this will be able to allow them to move around two axes, yeah, in two different directions. And our saddle joints, okay, if you have remember what a saddle looks like, is usually the bone is pretty much right, saddle shaped. Okay. And for instance, usually this is a more glorified condyloid joint, but will be able to move in at least all two axes. Now, the last one over here, the type is ball and socket joint. These type of joints is really freely movable. So they allow the most movements of any joint. So for instance, this is an example of our hip joint where we can move triatrially. Now, can you think of another ball and socket joint in your body? Right, your shoulder joint. Yeah. All right, so there are different factors that are going to affect how much you can move. So we can say they will affect range of motion. So it really depends on the two bones that are articulating together, how they are structured, yeah, and as well as their shape. So that would determine how close they will fit together and move together within the joint. Now, also, it depends on the muscle and the joint ligaments that are holding them together. So, how much, how well, and how tense the muscle and the ligaments are, then will vary your different positions. Now, hormones may be also affecting, for instance, the range of motion, especially in female during pregnancies, towards the end of the pregnancies, when they're ready to deliver, relaxin, a hormone, is released, and they will make a lot of joints more loosely fitted. So to be able to allow the baby the, uh, to exit out through the birth canal. Also, disuse will cause, for instance, changes in the range of motion. So, for instance, movement tend to be restricted if a joint hasn't been used for a longer period of time. So for instance, if you're wearing a cast, and this might allow you limit your range of motion, and so usually after the cast is removal, you actually have removed, then you actually have to regain some of those muscle strength and everything in order to move. Yeah. Now we're going to take a close look at several selected joints of the bodies, and starting from our first one, temporomandibular joint. We'll take a look at our shoulder joint, the elbow joint, hip joint, and the knee joint. Now each time when you're taking a look at a particular joint, pay attention to which two bones are involved, or sometimes maybe more than two, and also take a look at what type of joint they are and what motions are allowed. So first, let's take a look at the temporal mandibular joint, or TMJ. So TMJ, so which bones are involved here? I know you study your bones, right? So you have your mandible and the condylar process of the mandible you can see over here, right, with your temporal bone. Yeah. So the bones are involved are these two, and so these type of movements that is involved is, for instance, type of hinge and sometimes planar joint. Okay. Now, so if you can move your mandibles, you can do several movements. You can, for instance, elevate it, by closing your jaw. You can act like surprise when your jaw is dropping by depression. You can protract it to protraction, retraction, and slight rotations. Yeah, so various movements are allowed, okay, at this regions. Okay, now let's take a look at some of those um, ligaments. So over here you can see the ligaments binding the two bones together. Okay, and we also have articular capsule, and you can see it a little bit better on this side. You can see the superior compartment versus the inferior compartment in your, for instance, synovial cavity. Okay. So let's now take a look at our shoulder joint. So which bones are involved here? Right, head of the humerus fits into the glenoid cavity, right, of the scapula. Very good. Okay, so those are the two bones that are involved. So what type of joint is this? Right, this is a ball and socket. Okay. So this pretty much allows all types of movements, as you can see. Now I just want to point you to some structures. Here, if you see here, okay, are your articular capsules, okay, and that surrounds your articular. Here's another articular capsule, so you can see the inner layer is your synovial membrane. The outer layer, here, these are your fibrous membrane. And enclosing it is your, for instance, regions, synovial cavity. Yeah. We also have the structure of the labrum, which help, for instance, give support, attaching the joints more. And also we have the bursas, okay, that acts also similar to a synovial cavity, but outside of it to give support and reduce friction. Now, some of the times you may have experienced a dislocated shoulder, right? So it's either through injuries or other sorts of events that your shoulder is dislocated. They move out of the socket of the glenoid cavity. So usually it's easily treated, but you should definitely see your physicians to do so. Here is other examples of the ligaments that will hold and bind the two bones together. For instance, you will always see that if you break it in half, then you'll see the parts that are coming together, like glenoid humeral ligaments bind the glenoid cavity to the humeral part. Yeah. And let's take a look at our elbow joint. So which bones are involved here? Right, our humerus, with the other end of the humerus, yeah, and as well as our ulna and our radius. So now what type of joint is this? Right, this is a hinge joint. Okay, and over here I want you to be able to see some of the ligaments, for instance, annular ligaments of the radius, and we also have our ulnar collateral ligament that are holding it together. Now here is your articular capsule, and within it is your synovial cavity. So here is another, our radial collateral ligament. Now a lot of times people will play tennis a lot, and if there's any improperly, for instance, backhand, this tends to cause what we call a tennis elbow. So this tends to have pain as well as region discomfort near your lateral epicondyles of the humerus. So this, unless it's released and, for instance, rested, then you might continue to be feeling the pain and the swelling and everything. Yeah. Now our hip joint, okay, which bones are involved here? Right, this is the head of your femur that fits into the acetabulum. Right, so here's your acetabulum region, but you also have acetabulum labrum and your synovial cavity in between. So here you definitely have lots of ligaments holding them together as well to make sure they are well supported. And this ligament of the head of the femur came out from your fovea capitis, the little dimple on the femur, and attaches it to secure it onto your hip bones. Now you can also see ligaments that are attached from the ischial part of it, of your hip bone, to the femoral part. So what type of joint is this? Right? This is another ball and socket type of joints. Now let's take a look over here. You can see other ligaments, the pubofemoral from the pubic region, or the iliofemoral ligaments. Yeah. So if you break the words down, you can see where the two come together. Now our knee joints, this is the most complex one. And so which bones are involved over here? Right, you have your femoral bone as well as your patella as well as your tibia. So now do make notice that your fibula is not directly attached to any of these to the femur, but it is attached and help with to your tibia. So what type of joint is our knee joint? It is a modified hinge joint. Okay. Now, first, let's take a look over here. Here is your patella. Now, we actually are the muscles right here, or are your part of your quadriceps femoris muscle. Now, one of the tendons has been cut off, but you can see the tendon extended all the way to your patella. And below, you have your patellar ligament. Now, on the other side, you can see the medial patellar retinaculum, and you also have our lateral patellar retinaculum as well. And we also have our tibial collateral ligament holding on this side, and the fibular collateral ligament, okay, on this side. Now your articular capsule, if I'm kind of drawn over it, is more inside of everything. On the back side, you can see the articular capsule containing the synovial cavity, and you can see some ligaments, the oblique ones, going diagonally. Okay. Now let's take a look over here, a closer look without all those other ligaments showing. So you can see the condylar, the medial condylar, as well as the lateral condyle and regions. So if we were to take away the top portion, okay, you should be able to see the meniscus. So if we orient ourselves, anterior versus posterior, okay, here is our medial part. Okay. Medial meniscus is what we call a C-shaped fibrocartilage padding, cushioning pads. And the lateral meniscus is our also what we call an O-shaped cushioning pad. Okay. Now, two very important ligaments that help keep our knee joint in place is one is coming from the front, going backwards, is your anterior cruciate ligament, ACL. Now, 70 of any knee injuries occur right over here at this anterior cruciate ligament. And you can see it, for instance, going backwards. Here is your ACL. Now, your posterior cruciate, PCL ligament, is the ones right over here and over here. So these two actually try to hold your knees in place so that your femur either doesn't move too forward as well as your tibia doesn't slide backwards. So they're very important to hold everything in place. And you can see a little bit here better from a posterior view. And so your anterior cruciate ligament right over here and posterior cruciate ligament right over there. Now, as we age, so many things happen as you get older, but you should take good care of yourself starting now. Now, so osteoarthritis sometimes is partially age-related, and so changes occurs in our joints. And for instance, aging usually results in something of our cartilage, articular cartilage that are surrounding the bones. Usually it's thinning out. Okay, so also we tend to have, for instance, less production, decreased production of our synovial fluids, yeah, in our joints. So that would reduce, yeah, all the synovial support in these joints, creating more rubbing sensations, pain. Now our ligament tends to shorten and they loses their elasticity. So we tend to have more aches and pains as we grow older. Now, so it might come to a point, hopefully not, but if it's really needed, then we can have replacement of, for instance, a knee joint or a hip joint. So arthroplasty, meaning replacing, for instance, your joint regions with other type of materials. So if you take a look over here, you could have either total or partial knee replacement. If it were preparing for total knee replacement, they actually first remove your patellar surface a little bit. Yeah. They also have to remove part of your femoral surfaces and remove part of the tibial surfaces in order to input new knee joints, yeah, into each part. But you could also just have partial knee replacements. And we have specific parts for the femoral part, for the tibial component, for the patellar components as well. Now, so we could have either partial or knee replacement depending on what the patient really needs. And we also could have partial or total hip replacements. And for instance, for total hip replacement, they actually have to reshape the acetabulum on the hip bone, and they will have to remove the head of the femur and or install sometimes even artificial metal shaft onto it. So now just be sure patient with these replacement, they should not go through, for instance, MRI, magnetic, and they may activate metal detectors. Yeah, so to be very careful about it. Now here is rheumatoid arthritis. I've probably heard of it through a lot of commercials or family and friends who might have suffered from RA. So this is actually an autoimmune disease, and where your own antibodies end up attacking right here, your joints. So as they attack regions of the joints, your synovial region, it causes inflammation, swelling, and pain. And if worse come to worse, is what we call you don't see the joint anymore, but or a fusion of the joints. So this is where the finals occur, where the joint fuse and become a bony joint. And it becomes a continuous stretch of bones. That means you have lost mobility in these regions. Okay. So here is the end of chapter 9. So we'll see you in class or in another video lecture.